This episode is brought to you by podiatrygrowth.com/Pod Patrol.
So for the Pod Patrol listeners, what should they do to take advantage of the assistance that you can provide?
I worked with Jeff here to create a 5-day email course talking about 5 different systems that are going to help you drill down on what's important as far as gaining new patients. And if people enjoy that, I always have the option of 30-minute free strategy session where we kind of go over what people's current challenges are.
So a 5-email introductory course. That sounds expensive. What are we paying for that? $1,000? $10,000? What are people going to expect to pay for that introductory course for them?
Yeah, this is a free gift to my colleagues. Just gives you an opportunity to do a bit of a self-assessment.
If anyone's interested in more information, they can go to podiatrygrowth.com/Pod Patrol.
All right, welcome everybody to the live Pod Patrol podcast coming to you from Las Vegas 2026, ACFAS 2026. Joined by my esteemed colleagues here. Thank you everyone for joining us on this podcast. This will be recorded and released on the Pod Patrol podcast very soon. So thank you everyone for joining us on this live podcast. I'm honored to be invited to perform, I suppose we can say, but provide this live podcast informational content for people. For anyone that doesn't know, I host the Pod Patrol podcast. It is available on Spotify, Apple, and YouTube. It is designed to be educational content that is not boring. What do we think? Decent? All right. Doing my best for you guys. So trying to make educational content that is not boring. For anyone that doesn't know, my wife, Ashley, teaches at Des Moines University. Shout out DMU. I see my DMU peeps here. Thanks for coming. But she is a teacher at DMU, and we are interested in teaching the students and making a better generation of podiatrists. So thank you, everyone, for joining us here, and thank you to those listening on the podcast stream. Let's jump into the intro video and get rocking.
Every step matters. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Feet hit the ground, we rise, we climb. Ain't stopping now, it's our time to shine. Turn it up loud. Pod Patrol. Pod Patrol. Pod Patrol. Pod Patrol. Every step matters. Pod Patrol.
All right, welcome into this episode of Paw Patrol with your host, Dr. Jeff Dikis. Tonight, I am joined by nobody. I invited a few people to speak. Unfortunately, they had speaking conflicts. The idea behind this that I had was that we're in Vegas, and what better way to celebrate Vegas than a little bit of gambling? So I've got a roulette wheel where we're going to spin the roulette wheel, and we're going to have a debate. So I might have to call on like Kevin or Mason. One of you guys get up here to debate me. What do you think? No chance? All right. Think about it. Come up if you're ready. But for those who don't know me, I'm Dr. Jeff Dikis, Instagram FootDoc Duo, co-host the Gatekeepers Journal Club with Brad Abick, who should be here in a little bit, and a MIS Adventure Series, which is a limited series podcast on minimally invasive surgery. I'm clinical faculty at Des Moines University, and I work for McFarland Multi-Specialty Clinic, which is the largest multi-specialty clinic in Iowa. So this is how we all feel. At least that's how I felt a little bit this morning. I probably should have wrapped it up a little bit earlier, but it all sounds well and good when you're partying in Vegas until the next morning when you wake up and you realize that maybe you went a little bit too hard. And Vegas will suck the life out of you. It will take all of your money and not care. So is anyone here up? Is anyone gambled and is up? Liar. How much? 600. All right, lunch is on you, Mason. All right, you guys ready to let the dogs out? This is one of my favorite movies. I had to throw that in there for us. So these are some things that I think that are at the height of what we do right now. And so I think one of the most interesting things that we can do is have an open debate, an open dialogue about these things, because everyone's going to have their different opinions. Everyone's going to have their different dogmas, the way that they were trained and the way that they go about things. We could ask everyone in this room, and I bet none of us will agree on any of these topics here. We will not come to a consensus. And I think that's what makes these type of things interesting. These are not unique to this podcast. There are topics and tracks like this in the main area, but I thought it'd be interesting to go through some of these and debate these. So I'm going to debate myself here, and we're going to talk through these things, and you guys can ask some questions, because I think the interesting thing about these topics is that there isn't really a right answer. You can come at it from one side or the other, and you can make valid, good points. I kind of view this as a high school debate where you don't really know which side you're going to be on. So that's how I feel about some of these things here, is that if you tell me which side to argue, I could probably make some pretty good points on either side. Now, I tend to skew one way or the other when it comes to doing some of these things. I think minimally invasive surgery is the future. I host podcasts on minimally invasive foot and ankle surgery. So obviously I'm passionate about minimally invasive surgery. That doesn't mean that's all I believe in or that's all I do. I just think that there's so many benefits that come from minimally invasive surgery that when you compare it to the open alternatives, it doesn't make a whole lot of sense to me to continue to do something the old way if there's a new and better way coming down the line. So let's see if this works here. All right, we got the roulette wheel. We're here in Vegas. We're spinning. Who put it off? Mason, should have put that 600 on red. Double it up, man. Usually I try to double it up. I just lose all my money. All right, Haglund's open versus MIS. So we're going to talk about Haglund's open versus MIS. So don't worry about getting older. You're still going to do dumb stuff, only slower. So all of us are getting older, and sometimes we get stuck in the ways of what we do. You have to learn to adapt sometimes. Maybe you don't. Maybe you find a way that works for you, and maybe you find something that has good, reliable outcomes for your patients. And maybe that's a tried and true way that you treat these people and you don't have any issues with it. If you've been doing an open scarf for 41 years and your patients are happy and they have good outcomes, maybe you don't need to change. Maybe you don't need to learn any new techniques. But I think you do need to be open to learning new techniques and open to what technological advances are coming in the field and what might make better outcomes for your patients. So let's talk about Achilles Haglund's deformity open versus an MIS approach. So specifically MIS Achilles Haglund's deformity resection, not an Achilles repair. We can talk about that later. So I think the important thing to talk about here is which patients to choose which. Later, we could talk about an MIS Zadig, and a Zadig is a reasonable option. Tyler Gonzalez is a friend of mine. He's a MD foot and ankle ortho down in South Carolina, and he's published more than anyone in the world on the MIS Zadig. He has fantastic papers, but him and I still get into battles and arguments about which is the preferred option to tackle these posterior calcaneoenthesophytes. Historically, we would tackle them via an open approach. What does that look like? Well, it looks like this, which is fantastic for the surgeon, but there's a balance there. What's fantastic for the surgeon and what's fantastic for the patient? With this is fantastic for us. We get a good visualization of the calcaneus, the enthesophyte. I can resect the tendon. I can get a good, easy, open access to that, and I can debride any of that nasty, thickened tendon that you see in there. But we know that there's complications. Anytime you open up in an area that maybe doesn't have the world's best blood supply, you're maybe going to have some tenuous healing, especially in certain patient populations, diabetics, smokers. We know the list. We don't have to go through all those. So if there's a better way to do something, maybe we should learn how to do it and at least use it as an option. So what does this entail? I'm going to argue kind of both sides of this because an open approach is tried and true. Like I said, you can tackle that tendon. I don't know if we need to touch the tendon though. The outcomes for an MIS Zadig and an MIS Haglund's have been shown to be so good without touching the tendon that I don't know that we need to touch the tendon. I think some people would argue against these and say, well, the tendon is thickened, it's nasty, we got to get all the chunks of junk out of there and then take the bone off. I think that's a reasonable argument. And if I'm arguing against myself, that's probably what I would say. On the flip side of things, when you factor in the incisional issues that we've all seen, if you do enough open Achilles, you're going to find some who don't heal like you thought, whether it's a reaction to the implanted material, whether it's an issue with the incision, maybe you didn't check their nicotine level and they didn't mention that they were a smoker and you find out later they were a smoker. Maybe their vitamin D level is 7. I've had that happen before early in my career. That is obviously a hindrance to healing. Now I check a vitamin D level on every patient pre-operatively because I've been burned before and we know how much vitamin D is important in healing. So what do I do here? This is me in the OR and it's pretty simple. You make a few portals here. You use the MIS burr. How many people have done an MIS Haglund's resection? Just a couple. Okay. So I'm not telling you stuff you already know. So what you do is you make a few portals there, four portals, kind of 2 and 2 in a box. And you go in and you lift the soft tissue off of the bone the best that you can. And you stick the burr between the tendon and the bone. You can see here, I've got a rasp and then the burr in there, and you're resecting off whatever you want to. Whatever you would take off with an open approach is what you could take off with an MIS burr. This was my first one that I ever did. And I was a little nervous about figuring out, okay, what does it look like in there? What's going on? So I actually used a small scope to stick in there while I was debriding to kind of verify that I was resecting what I thought I was resecting, that I wasn't damaging anything, that I wasn't realizing that I was damaging, and use fluoroscopic visualization. You can see here that I have it lined up as a lateral, which is obviously the view that you want to be able to check. And you just burr a little, check, burr a little, check. And so one of the important things about this procedure that most people don't realize is that you are intending to release the tendon from the bone. And some people think, well, isn't that creating an Achilles tendon rupture? Yeah, it kind of is. But we do that when we do an open approach too. When you do the inverted T incision, you flap it open and you resect the bone, and then you anchor the tendon back down to the bone. It's really no different than that. You're just doing it via a minimally invasive approach. So when we do that, we keep the incisional incisions very small, and so limited risk for the patient when it comes to healing. This is what I like to do once I get that little slurry. If anyone's done any MIS surgery, you know that it creates kind of like a little slushy slurry. Try to get that out of there. The last thing you want to do is have a bony slurry that is sitting back there at the posterior aspect of the calcaneus that's just going to consolidate and turn back into bone, recreate the problem that you were trying to solve in the first place. Once you've done that, you're pretty much done. You need to insert your wires, check a calc axial to make sure you're center. I've made that. Everyone who's ever tried to throw calcaneal wires has touched the fibula and the lateral gutter and said, whoa, hurry up, give me that wire driver. I need to change that real quick. That's not looking very good. So don't just rely on your lateral. Make sure you check a calc axial to make sure your wires are center where you need them to be. And then you go ahead and you put your anchors in there. I like to test this as hard as I can intraoperatively. Why? Because if it's going to fail, you want it to fail in the OR. I do not want it to fail at the first post-op visit, second post-op visit, etc. I want them to fail in the OR. I will pull on these very hard to make sure that they are anchored into the bone. Once I've anchored them into the bone, obviously you want to check your Thompson test, make sure that you've reattached the Achilles. The interesting thing about this is if you've ever done an open inverted T resection off of an Achilles, you know that you try to keep those peripheral fibers intact. So there's no retraction of the tendon. When you resect off the posterior aspect of the calcaneus, the tendon doesn't just snap and retract back up into the leg. It releases from the most posterior central aspect, but it is not released off the periphery, off that side aspects of the bone. And so it's pretty easy to get your tension correct because the tendon has not retracted at all. It's basically out to length. But I do like to verify Thompson test to make sure that I have attached that back into the bone properly. And this is my view from the scope. I labeled it because otherwise it looks like a snot rocket from, one of my boys. But you got the Achilles here and you got your suture and you got your anchor. I wanted to kind of take a peek inside and look at what it looked like on the inside. And it's really hard to see what the heck you're doing because we're used to looking at scopes. We're used to sticking cameras inside the ankle, finding our horizon. When you do a scope somewhere else, it takes a little while. Like what's up, what's down, what's front, what's back. And so I don't think a scope is a necessary part of this procedure. It was mostly me just verifying that I did what I thought that I was going to do on this. So is open still viable? How many people here do an open Achilles detach, reattach? Okay, how many people do a Zadig? Nobody. Tyler's not here. He's going to be disappointed. You do a Zadig? All right, we got one for you, Tyler, if you're listening to this. So when we compare these two options, is open still viable? Again, I go back to what I said at the beginning is, do you have a wheelhouse of something that you are good at? Do you have reliable, reproducible results with your patients? Are they happy? Do they have good outcomes? Are they successful? Then stick with it. If not, if you've had any of those kind of incisional nightmares that we all have literal nightmares about when they walk into your office and you're staring at tendon or you're staring at fiber wire or whatever it may be. I've had that before. You're looking at it, you're like, oh, I think, yep, that's not good. So then you're worried about grafting, all that stuff. And so is the technical demand too high? Well, you could make an argument that most people stick with the tried and true because it's what they're used to. And the technical demand of learning any new procedure, whatever it may be, exists. But for this, I don't find it to be too technically demanding. The alternative would be an MIS Zadig. Very reasonable. Again, another approach where we don't touch the tendon. The reason we know that we don't have to touch the tendon is that because if you look at the research that supports an endoscopic gastroc recession for isolated insertional Achilles tendinosis, they have good outcomes. Not fantastic outcomes, good outcomes. Probably about 70 to 80% success rates. So we all know equinus could be a driving factor behind this. So if you're controlling the underlying factor of what's developing the problem in the first place, do we need to do anything else? And some people might say, well, if equinus is the driving factor behind this, aren't you not addressing that with an MIS Haglund's approach? And what's interesting about this is that when you detach the tendon posteriorly and you reattach it after you've resected the bone, it's really no different than an open approach. If you think about it, you're anteriorizing, I don't know. You're moving the tendon anterior on the bone and effectively shortening it because you've moved from a more posterior distal attachment to a more anterior proximal attachment. So you are effectively lengthening the posterior muscle group and the Achilles by doing that. And same thing works with a Zadig. When you take that wedge out and you anteriorize that and you rotate it forward, you're effectively shortening the Achilles. So I would say, if I was going to argue, if I was going to pick the side, I would say MIS Achilles is superior to open approach. Again, there's a caveat to that, which is if you're good at the open approach, stick with it.
We'll be right back after this. For more information, go to podiatrygrowth.com/Pod Patrol.
So the people have signed up for the 5-email course and 30-minute free conversation with you to analyze where their marketing needs improvement. What steps can they take next?
Yeah, the next step is a deep dive. It's what I call an online practice x-ray. I look into your Google Analytics, your Google Ads. And then the last part of the online practice x-ray is to provide you high ROI marketing plan. It's a really in-depth diagnostic that will give you a clear direction about what those next steps are to help you grow your practice. This is something I generally charge $2,000 for, but since they're Pod Patrol listeners, we're going to chop that in half and charge $1,000 for this diagnostic. You'll have a written document at the end with the competitor analysis, what you're doing now, and a clear marketing plan to make sure that you can be cost effective when it comes to marketing your practice.
Absolutely. I love to hear that. Paw Patrol listeners are getting 50% off from Jim McDaniel, marketing expert at podiatrygrowth.com. If anyone's interested in more information, they can go to podiatrygrowth.com/Pod Patrol.
You guys want to come rotate with me again and learn how to do an MIS Achilles? Yeah? All right, let me know. All right, let's spin the wheel again. Brad is apparently MIA, so I'm on my own. Here we go. Oh, not again. All right, got to the next one. Fix the deltoid or the syndesmosis. This one is controversial. When we tackle ankle fractures, we get x-rays, obviously. When we look at that x-ray, I think that there's a significant difference between these two x-rays. If you're inexperienced, if you're young, you might look at these and kind of start to think similar things. But the one on the left has a transverse distal fibula fracture with mild lateral translation, but that talus is significantly laterally displaced. With this, you're thinking about a syndesmotic injury and a deltoid component to that, versus the one on the right doesn't look like it has any syndesmotic instability. But I've been fooled before. So what we're going to learn from this is that you can't trust an x-ray. An x-ray is a static image of a dynamic person. They walk, they move, they function, the bones articulate, they glide, they move. We have joints. You cannot look at a static image and know what the dynamics of that joint are. We have to test it either mostly intraoperatively with live fluoro, or at least have an aggressive physical exam, which I don't do. Some people test this in the office. I think that's torture. Poor people have some injury and you're going to stress them and pull on it and crank on them. I mean, that just sounds absolute. I probably wouldn't go back to that doctor. If I hurt my ankle like that and I walked in and they started cranking on my ankle, I'll be like, this guy's crazy. I'm not going back there. So we have to draw a big distinction here between deltoid, syndesmosis, or potentially both. So when we have a fracture historically, and I've been doing it for a very long time, even if there's a deltoid component, you can make an argument that by indirectly stabilizing medially by repairing the syndesmosis is good enough. In my experience, sometimes it is and sometimes it isn't. What does that mean? It means that you maybe you do a plate. We'll talk about plate or intramedullary nail into the fibula later. Well, let's say we do a plate on the lateral fibula, and then we stress and we see that the syndesmosis seems to be unstable or widening, and I fix the syndesmosis. You can then say, okay, I'm done. And most of the time that's okay. You've indirectly realigned the medial gutter by fixing the syndesmosis. Where's it going to go? It can't really go medial lateral. But if there's a deep deltoid component that you don't appreciate, you're going to get talar tilt. You're going to get more on the picture on the right where you see the tilting of the bone compared to the translation of the bone. There's a big difference between tilting medially and translation, I've found. And so what that means is you want to crank on it and you want to figure out what the heck is going on in there. Where is it unstable? If you just looked at this x-ray right here on the upper right, that you took that picture in your office and you said, I don't see any problem. I think you're fine. I don't know what you're talking about. You seem to be, everything looks good. Your mortise looks good. No increased medial clear space. Everything looks fine. And then you get them under anesthesia and you start cranking on it and you realize, wow, this thing is all over the place. This is very different dynamically compared to the static image of the x-ray that you took originally. So what does that mean in terms of utilization? What do we have to keep in mind when we have this information? We know that there's multiligamentous instability. So here's a little bit more obvious syndesmotic deltoid instability, right? We can see just one glance at that. This is a static image, but I can tell on the static image that this is not good. There is multiligamentous damage, instability, there's lateral translation, all the above. This is actually one of the more simple injuries to fix because once you've closed, reduced this, gotten this back into better alignment, most of your work is done. So this is one where I opened it up, reduced it, plated it, stabilized the syndesmosis. And you think, okay, you're done. And maybe you are, but you don't know if you're done yet. You have to do one more thing, and that's stress medially. You have to stress the deltoid component after repairing the syndesmosis because I've been burned before where I fix it. It looks fantastic. Again, a static image. You look at that static image. You're high-fiving, you're walking out. Let's get some lunch. Fantastic. And they come into your office a little later, and all of a sudden the talus is starting to peek out medially, and you think, uh-oh, that's not good. So you get burned enough times, you realize it just takes an extra 5 seconds to stress medially and figure out if the deep deltoid component is involved with this injury. Obviously, we know there's some amount of deltoid injury, and I've done lots of podcasts with lots of very smart people, way smarter than I'll ever be. And nobody can seem to put their finger on why sometimes you fix the syndesmosis. Even with the image on the left, you know that there's deltoid instability. You know that there's tearing of at least part of the deltoid. But when we repair the syndesmosis, it seems to be stable. You test it and you're like, oh, it's good. I don't think I need to fix the deltoid. Versus sometimes you do the exact same x-ray, exact same repair, you stress it and it opens up. I haven't found anyone who's been able to put their finger on why that exactly is. What components of the deltoid, spring ligament, all the above that are involved in that complex of what gets torn and what needs to be fixed. So I think the easiest thing is not spend too much time figuring out what's torn, how it's torn, where it's torn, but figuring out, do we need to fix it? And that's a very simple thing to do after you repair this. Fix the bone, fix the syndesmosis, and then figure out if you need to fix the deltoid. Deltoid, I think, has been chronically undervalued in the circumferential ligaments of the ankle. We spend so much time over at the lateral ankle. We do ATFL, Brostrom, imbricate, pants and vest, old school, Christman snook. We talk about that all day long, lateral ankle, lateral. And that's fine. We can focus on lateral. That's all well and good. Lots of people have lateral ankle instability. Medial ankle instability is a bigger problem, I think. If people have medial ankle instability, it causes a lot more train wreck, a lot more issues than lateral ankle instability. I think some people get a little overwhelmed or a little intimidated with going medially because we know the neurovascular structure rides along that medial aspect. And we don't want to go anywhere near that. We're taught to leave that alone. But I've started doing a minimally invasive deltoid repair. and it's actually very easy. And so if we're worried about going medially because we don't want to mess with the soft tissues, the saphenous, the neurovascular bundle, this is a very simple approach. You can see here on the left is the typical, it's probably overkill. It's probably not quite that big, but the typical open approach along the medial aspect. And then in red are my 2 incisions that I use to do a minimally invasive deltoid approach. And so if you make those 2 red incisions, you can spread bluntly down to the bone. You're going to try to find the medial malleolus, kind of the distal inferior tip of the medial malleolus. And then you're going to try to find the the medial aspect of the talar body. You can see on the top right where that anchor is aimed right into the talar body. So I'm putting an anchor into the medial malleolus and an anchor into the medial aspect of the talus. If you look at that green arrow on the top left and bottom right, one is before, one is after. It's subtle because you don't necessarily want to crank it down and over constrict and tighten it too much. You want it to be anatomic, rectus, all the things that we're taught where it's equal and symmetrical all the way through the ankle joint mortise. But if you drill into the medial malleolus, I use an all suture anchor. Doesn't matter what company, doesn't matter what brand, but I use a tensionable anchor. That's the key part of that, is tensionable. So I don't have to see what I'm doing in order to tension that. So I put an anchor in the medial malleolus, tails come out. I put an anchor into the medial aspect of the talus, tails come out, and then I cross them. I take the tails from the medial malleolus, cinch it into the anchor from the lasso, the tightening stitch from the talus, and vice versa. So one is getting anchored from the medial malleolus to the talus, and the other is getting anchored from the talus to the medial malleolus, kind of in a crossing fashion. And that seems to work well for people. It's a very small incision, very small footprint that you're doing, and it takes maybe, if you get good at it, maybe an extra 10, 15 minutes. But what you're saving here is a whole lot of headache down the road. In the future, if you neglect the deltoid injury and you start to see that talus tilt, you're going to wish that you spent that extra 10, 12 minutes stressing the deltoid, figuring out if the deltoid was a problem, and fixing that when you're in there. So is it necessary to fix both? You can make the argument that you're not wrong to just go ahead and fix both. Fix the syndesmosis, fix the deltoid every single time. It's stable. You're not going to miss an injury. I don't think you necessarily need to do that. I think with trauma, you can fix the bone, you can stabilize the syndesmosis, and then test medially and figure out if that needs to be fixed as well. What about the AITFL, anterior inferior tibiofibular ligament? AITFL, part of the syndesmosis, the anterior component of the syndesmosis. That's important to stress because I had Bob Anderson, probably maybe the world's most famous foot and ankle surgeon, on a podcast with me, and he was very adamant about testing the AITFL, especially in high-level athletes, NFL players, because neglecting the AITFL, let's say that, picture that you have a full thickness anterior syndesmosis rupture and you fix the syndesmosis, you're going to potentially have rotation of the fibula. You're going to malreduce the syndesmosis unless you stabilize the AITFL first. If you stabilize the AITFL prior to fixing the syndesmosis, then you're going to get congruent reduction and it's going to be a lot more successful. All right, we'll do one more here. Oh, this is a good one. I'm doing research on this right now. Okay, so this is a pretty typical ankle fracture that we see. Bimalleolar, potentially trimalleolar. Get multiple views and figure out if there's a trimalleolar component. It's not going to necessarily change whether I do surgery, but you want to be aware of it. So we have circumferential fractures around the ankle joint. So historically, we're taught AO principles, right? Have any of you guys been to AO? Yeah, like AO course? No, they have AO basic and AO advanced. And they teach you all the AO principles, right? Okay, here's how you fix bone. Here are the things that we do to fix bone and get it to heal. Primary healing, secondary healing, all the things that come with bone healing. Historically, we've talked about utilizing neutralization plate, which means you put a plate over top of the fibula fracture with a lag screw. That's classically how it's been done. For the last 10 years, I've been fixing ankle fractures without a lag screw. Why? I just think they're completely unnecessary and they heal without this. And I'm pulling all of my ankle fractures and going through the data. And so far, I've had one non-union out of over 100 ankle fractures where I did not use a lag screw. And that patient was rather compromised. Hemoglobin A1C above 11, non-ambulatory fella with some significant health issues. So does primary or secondary bone healing matter? So primary bone healing would be if we put that lag screw across there and we plate it, and then we use it functions as a neutralization plate. Secondary bone healing would be if we put that plate on there and it functions as a bridge plate, same construct. It's just what are the physics of the bone and how are they healing? How does the bone respond? It gets way beyond my level of comprehension in terms of cutting cones and osteoclast and all the things that happen on a cellular level. Just need to know that if you use a lag screw, the function of the bone heals differently than if you don't. But does it matter? Do we need compression of a fracture in order to get it to heal? I would say no. Do we want fracture ends across the room and hope that they come together magically and heal? No, that's not good either. They can be kind of next to each other and still heal. We want stability. We don't necessarily need compression, and the research bears that out. So this is how I fixed this construct. This one is a little more complicated because it did have a tri-mal component. It did end up having a rather large posterior component. And we're going to get a CT scan on this. This is one where you're a home run. You're absolutely going to get a CT scan, evaluate the intra-articular nature of the fracture, look at the tri-mal component, fix lateral first, put your plate on, stabilize, fix medially. And then I went medial, posterior, medial to attack that posterior mal fracture, kind of a posterior medial approach here. And then I had to kind of squeeze my little syndesmotic button in there. And so this is one where I did not use a lag screw. Again, if you look at the research, there's numerous papers out there that looks at the necessity of an intrafrag lag screw using a pre-contoured lateral locking plate. Specifically, they looked at Weber B fractures, supination, external rotation fractures, and looked at the necessity of the lag screw. Historically, this contradicts everything we've been told from an AO standpoint. So AO does not like that, and I get it. But sometimes not everything fits perfectly neat into all of the AO concepts and all the things, all the dogma that we've been taught for such a long time. We need to sometimes go a different way, figure out what might work better for us, and see if it works. Like I said, I've historically not been using a lag screw for the last 10 years, and I've had one non-union of a fibula fracture. So from my standpoint, I think a lag screw is absolutely unnecessary. I do find some people who will argue the alternative and say that it takes an extra couple of seconds. You're providing rotational stability. You're getting a little bit of compression across the fracture, and you're getting primary bone healing instead of secondary bone healing. Those are all very reasonable arguments, but they're also theoretical. They're also scientifically theoretical, which means when you're saying those things, you're inferring that you need those things in order for bone to heal. And if you fix enough fractures, you'll see that you don't always need the things that are scientifically proven or scientifically theorized to be necessary for bone healing. So this is one where I kind of went off script, started not using a lag screw, and it hasn't seemed to matter. All right, I'll do one more. Kevin, pick one. You want to come up and debate me yet? Anybody want to debate me? Nobody. Okay, cool. Mason, come on up. I don't know. We'll just have fun. Come on up. You're good, man. All right, let's talk about fibular plate versus nail. So introduce yourself to the podcast. For anyone just listening on the podcast feed, there are about 450 people here in the audience.
So I'm Mason. I'm a fourth year from Des Moines University.
Where are you at right now?
I'm about to go to Oklahoma for my core rotation.
All right, so you're a fourth year?
Yeah.
You're out on rotation, so we won't expect you to know anything. So when we look at this type of fracture here, obviously this is a rather significant ankle fracture, right? We have ankle fracture dislocation, posterior dislocation of the talus on the distal tibia. We have a distal fibula fracture. We have increased medial clear space. First thing we're going to do, I like when it says it's broke. ER calls me, hey, it's broke. Yeah, I can see that. Thank you. So what are we going to do? We're going to reduce that. We're going to put that back together. And in this case, this is one. So historically, I think people have been a little hesitant to use intramedullary nailing. Have you seen any intramedullary nails? Okay. So if you had to, tell me in your point of view, what type of fracture would you try to nail? Do you have any thoughts on that yet or no?
I would say I'm a little rough. I'm a little rough when it does come to that, just because I've only seen one.
Yeah, you're good. So historically, it would make sense that you would nail a fracture that has very minimal displacement, right? Because the whole reason of doing an intramedullary nail for the fibula is that you're making minimal incisions. You're not opening it up, right? And so we're going to do that through small incisional approach. And the more displacement of the fracture, the harder it is to get reduced through those small incisions. It's going to be way quicker. If I was going to try to reduce this, it'd be way quicker. I could open this up, plate it, and be done in 20 minutes. Open it up, plate it, be done. With a nail, it's just going to take longer. There's more steps. You got to reduce, wire. I make a little mini open incision. So this is what I advocate for people who are doing fibular nails, because the last thing you want to do is we did a lot of orthopedic trauma rotations when I was in Pittsburgh. And one of the concepts of intramedullary nailing is, whether it's a femur or a tibia or something, the medullary canal meets the size of the tibial or femoral nail, right? So you can use the nail as a reduction technique. You can put your guide wire in there, you can ream, you can put your nail in, and you see the fracture come back together because the nail is doing the reduction for you. My mind went the same direction when I started doing these fibular nails and trying to figure out, okay, does the fibular nail perform the reduction for you? And I thought that it would, but it does not. So you have to make a small incision here, open this up, put a little clamp on it, get your reduction stabilized before you put the implant in there. I think this is the most important step that people neglect, because when you put your nail in, the last thing you want to do is have it displace and cause further displacement. So this is an example of a fracture that when I first started fibular nailing, I would never tackle that one on the left because it looks too complicated to me. It looks like it's too hard to reduce. But if you're able to get good closed reduction, good alignment of that fracture, then all you have to do is make that little mini open approach, reduce it, put a clamp on it, put your wire in, put your nail in. And so I think the evolution of the nails, I've had people on the podcast and big nail fans. You can argue the bent nail versus the straight nail versus the threaded nail and all the products that are on the market, and make different arguments for those. So dealer's choice on that. But if you are going to use a nail, I think the indications for this are expanding, which means you used to not tackle the one on the left with a fibular nail. But as you get a little more comfortable with your close reduction, manual manipulation, small mini open approach, open it up, clean out the fracture, wash it out, put a little lobster claw on it, spin it down, get your length on your fibula, hold it in place, then put your guide wire in. You're going to leave that clamp on the entire time, because when you drill, ream, and insert the nail, if you took the clamp off already, it's going to displace your fracture. So leave that clamp on the entire
I
time.
have a question.
Yeah, go ahead.
So
Say
I
in
will
here.
say, I will say, so my question is, just because like I don't see IM nail being used a lot, what I do know about it is like heat necrosis of that. So like, is it worth all the extra risk versus open and plating?
So I don't think that's an issue. So he said, is heat necrosis an issue? So I don't think necessarily heat necrosis is an issue with this, because the reaming is fairly quick. The other benefit of this, as equal to minimally invasive surgery, is I don't use a tourniquet. So if there's intraosseous bleeding, that does provide some amount of fluid and cooling that happens as well. Same if you're using an MIS burr, I don't use a tourniquet for that, because you're going to get some intraosseous or intraarticular bleeding and sludge. And so you don't necessarily have to worry about, I don't actually use any flush or saline during my minimally invasive surgery. That's a little controversial. A lot of people use saline because they're worried about thermal necrosis. I don't think it's as big of an issue as people make it out to be. But for this, no, not necessarily thermal necrosis. For this, it's more about maintenance of the reduction of the fracture while inserting the nail. Because if you can maintain reduction of the fracture when you put your nail in, then the nail is holding the reduction. But if you're impacting the nail without maintaining the reduction of the fracture, the nail is likely to displace the fracture, and then it's holding it in the wrong position. Now it's actually fighting against you instead of helping you. So which patients are we going to nail? You could pretty much nail any patient you want. There's a few patients that I would stay away from, and then definitely lean towards a plate. Those would be the ones with comminution. If there's multiple fragments of the bone, if there's a large butterfly fragment, that posterior butterfly fragment, that's going to be hard to contain with a fibular nail. And if you can't reduce it percutaneously, if you make a small open incisional approach and you put your clamp on there and you're not able to maintain your reduction or stabilize it, I would bail away from the nail and open it up and plate it. And I've had to do that before. Any questions about that?
No, I was gonna ask about your bailout plan, but that works.
Yeah, that's a good point. I mean, I haven't had to take any of these fibular nails out, except for ones that I put in and caused displacement of the fracture. I've had it happen twice, where I put a fibular nail in, and the fracture displaced, even with a clamp in there. And I can't figure out why, except I think I figured it out. It's certain patients have a very narrow fibular canal. If you only learn one thing from this, if you're going to put a fibular nail in, don't do what I do. I looked at the fracture and I thought, yep, I can definitely nail that. But with the intermedullary space of the fibula, you want to look at your x-ray and measure the medullary canal of the fibula before you choose to do a nail. I've had it happen before where I did not pay attention to that. There was fracture displacement. I threw a wire up there. The wire was so tight that it broke off in the fibular canal, and then you still didn't learn my lesson. I was like, oh, I can ream over that. I'll ream that through, put the nail in, no big deal. And I did, and I got the piece of the wire out there. But when I put the fibular nail in, even with the reduction clamp in place, the fracture slid over and had malreduction. So I've had to take 2 out for that reason. And I think it's directly tied to the narrow fibular canal. So pay attention to the medullary canal in your preoperative x-rays if you're leaning towards nailing these fibulas, because it can cause issues. So that's what I would take away from that. Look at your fibula canal before you decide whether or not to nail. All right, I'm losing my voice. I stayed out too late. Hopefully some of this was helpful for people. Hopefully I remembered to hit record on the podcast. And thank you guys for joining us on this episode of Paw Patrol with your host, Dr. Jeff Dikis. We'll see you guys next time.
Disclaimer. Opinions expressed are those of the content creators and do not represent any employer or entity. The information shared is for informational purposes only and should not be construed as medical advice or used in any legal capacity, including establishing standards of care. All efforts have been made to comply with HIPAA regulations. No guarantees are made regarding the accuracy of statements or opinions provided. Interaction with the podcast does not establish a doctor-patient relationship. Please enjoy this podcast responsibly.